Hey everyone, welcome back to my channel, and if you're new here, I am Mariana and I interview the brightest minds of physical therapy. So if you want to increase your knowledge, start right now by subscribing to this channel, clicking on the bell so you don't miss anything, give us a thumbs up and share with your friends. Today, our guest is Pepe Guillart and he's going to talk about diagnosis and treatment of headaches. Pepe is a physical therapist with almost 30 years of experience, McKenzie diplomat, and he has worked with professional sports teams. Pep has his private practice in Spain and he teaches his own headache course. I hope you enjoy the show. Hi Pep, welcome to PT Pro Talk. How are you today?
I'm fine, thank you. And thank you for having me in your forum.
Thank you, I really appreciate. And let's jump right in. So could you tell us a little bit about yourself, your career, and how did you get to where you are right now?
Okay, so I was born in Spain and I live in Spain. And I graduated from the School of Physiotherapy in Valencia, which is the third most important city in Spain after Madrid and Barcelona. And that was in 1992, so almost 30 years working as a physio. And after finishing my degree, I started working in sports, mainly in basketball until 1995, where I established my clinic, which is still my main job. I work in my own practice with more people. And I've been combining my clinic with some soccer teams, so on a professional level. But mainly my practice is my daily life. Yeah, that's it.
Awesome. So I know that you are super interested in studying headaches and you've been teaching courses. So just tell us a little bit how it started your interest in studying headaches.
Well, this was a personal thing. It was something that someone in my family and myself was suffering from headaches a lot, going to the hospital every now and then, and it was awful. And well, I happened to know physiotherapy who was treating mainly headaches, and I was able to treat that person. And well, after that, the success was amazing. And as well with myself, I was suffering from headaches and working on myself. It was good. So mainly was a personal interest. And after that, I was just curious, and I started to learn a little bit more, but because there are many things related to physiotherapy and headaches, so very good things, things you can trust. And yes, I started to do this, and that's why I don't treat many people with headaches in my clinic. So in the clinic, it's not like we are a headache clinic, okay? So it's not that my main group of people, what patients are headache patients. They are not, but yes, sometimes I do.
Okay. And how do you classify headaches and which ones do you treat?
Well, classifications is always, I think you can have as many classifications as you want, because classifications are made to try to get people sharing the same characteristics, the same pain patterns or symptoms patterns, So it's just a matter of having a homogeneous sample, mainly thinking about investigation. We would like to have diagnosis instead of classification. But when you don't have something specific, like happens with low back pain or neck pain or headaches, then you need to use other things like classification. So you need to gather and to try to put every people with more or less same characteristics in a classification. So I don't really use a classification. What I say is someone that responds to my assessment or doesn't respond to my assessment. So the people who I treat are the ones who respond to the assessment that I do on them.
Okay. I was reading about the types of headaches, the primary headaches and then the secondary headaches. And so the primaries are the ones that we don't really know the reason, right? Mm-hmm. Is that correct? You correct me if I'm wrong. And then the secondary is the one that we have the cervicogenic headaches, with the headaches that come from the neck. So when you are treating them, what are the characteristics on your subjective exam that would give you like a hint or a tip that would show you that the headache could come from the cervical?
Okay, so when you are talking about primary and secondary headaches, this is a classification from the medical model. Okay, headaches are within the medical model. Everyone in the whole world are using the medical model classification system. The International Headache Society is the big guy around the world, and they are the ones setting all the classifications, and they are the ones defining which is a migraine, which is a tension type headache, which is what's a cluster headache, okay, and what's primary and what's secondary. Primary doesn't mean that you don't know the cause. We don't know the cause for primary, but this is not the reason why they are called primary. Primary are called because the problem is the headache itself, okay? And secondary means that there is another thing causing the headache. For instance, if you have fever, okay, or you have cancer, you may have headaches because of this, okay? Or you can have a problem in your neck and having a headache related to the neck as a source of your problem. Then you have a secondary headache, okay? But primary means that the problem is the headache itself. It's not because of other things, okay? There is not an underlying cause for that, okay? And when I'm doing my subjective, well, it's very difficult. It's very difficult just from the subjective, from the things that the people are telling you, if you know, okay, this is going to be really cervicogenic or not. Why? Because migraine, tension type headache, and cervicogenic headache, they overlap symptoms. Okay, so they overlap symptoms, they overlap locations, they overlap type of pain. Okay, so it's very difficult to distinguish sometimes between one headache and another headache. So you don't really from the subjective are always certain to be dealing with a cervicogenic. If the patient is telling you that when he's doing some postures with the head or the neck, or doing some movements on some postures, and they say, when I do this, my headache comes or increases or it gets better, maybe you have a hint that maybe your neck is involved in this process. But other than that, it's really difficult just from the subjective to have a real positive headache, cervicogenic headache.
And how do you know, or I don't know if you know, which ones are going to respond to therapy, to physical therapy, that they're going to have a good result with the PT approach? Is there a way to know that, or just trying?
No way with the subjective. No way, unless someone tells you that he's suffering from headaches, and every time someone is treating his neck, he's getting better. So he's telling you, okay? But just because of the subjective is really difficult. Even with the objective, it's also very difficult. But in the objective, you may have some features that can lead you to think, oh, maybe we have something here. For instance, if you have a positive flexion rotation test, maybe if you are able to change this and the headache improves quickly, okay, maybe this is a cervicogenic headache. So the objective could give us more information than only the subjective.
And let's talk then about the objective. What else would you do that would show you that it could have a positive result with physical therapy? Maybe some like range of motion restriction, something like that?
Yeah, that's what I'm looking for mainly, okay? If there is a decrease of the range of motion. And the other thing I'm looking for is if I'm able to find muscle pain or muscle originated from muscle. So if I'm able to touch maybe trapezius and the patient say, oh, that's my headache, okay, so that's triggering my pain, things like that. But yes, I'm looking mainly for the range of motion in the cervical, upper cervical, lower cervical, and the upper thoracic. They are the main things. Because we are talking about cervicogenic, I also always have a look to the TMJ, okay, because they are the two main sources we have in the neck and in the head that are able to produce or influence headaches. Okay, yes, mainly I'm looking for this. Yeah.
And talking about the cervicogenic headaches, how do you differentiate if the symptoms are coming from the upper cervical or lower cervical?
By definition, upper cervical is the only cervical segment that can give you pain in the head. Okay, so you cannot have headaches from C6. Okay, so the source is always the upper cervical if you're talking about cervicogenic. But you may have a contribution from the lower cervical. Let's say you have a loss of extension in the neck, and this is changing the behavior of the upper cervical. Okay, maybe the upper cervical is giving you the headache, but because the lower cervical is not behaving properly and changing the way this is suffering. So maybe you are having the afferents from here altered because of the lower cervical. Okay. But you are always, if you have headache from the neck, the source is going to be always the first three segments, the top three segments.
Okay, and how do you know that the lower cervical is influencing the upper cervical?
Okay, this is not always that easy, but when I'm teaching the courses, I'm showing a couple of schemes that shows you hints that can lead you to think, okay, maybe it's very, very upper cervical with a little or no contribution for the lower, or you may have some contribution from the lower. And it's related to the range of motion, okay? For instance, if you have a positive flexion rotation test, now you for sure have an upper cervical issue. Why? Because the flexion rotation test is assessing only the rotation on C1 on C2. Okay, this is the only segment is assessing. So if you have a positive test, now you know you have something not working properly. Okay, you still don't know if this is the cause, because to say that, okay, this is the problem, you have to change this to normalize the range of motion, and the patient has to say, I'm better. Okay, so there has to be a correlation between now I move better and I feel better. Okay, so there has to be a relationship. And if you have a lower cervical involvement, usually you have more movement restrictions. If you have the upper cervical only, maybe the flexion rotation test is the only range of motion that you find decreased, okay? But the rest of them, maybe they are full and free, okay, pain-free. But when you have a lower, you usually have more than one movement alter with decreased range of motion, mainly rotations, extension of the neck, or even flexion, okay? Of course, lateral flexion as well. So you may have more decrease of the range of motions in the whole neck. Whilst in the upper cervical, you may have no symptoms at all. No loss of movement at all. Besides, you can have with the upper cervical problem, usually you don't have neck symptoms, and if they are present, they are really on the top, and not really bothering the neck. Plus, you feel mainly the pain in the head, whatever the area, okay, but in the head. When you have a lower cervical, you can also have only pain in the head, but usually you have more neck involvement, going to the trapezius, traveling down to the scapula, and things like that. So you may have other movements and other symptoms going to everywhere. Okay. Something like that.
Yeah, no, that was clear. And how do you treat headaches? There is any specific approach do you use, or how does it work?
Well, it depends. It depends on my findings in the objective, okay, and it depends on my findings in the subjective. Because if I have someone that is really afraid of me and he's scared and he doesn't want to be touched or anything, So I maybe have to use everything I have with hands off, okay? And I like to start with everyone, with knees, with elbows, with everything. I like to start with hands off. Why? Because I don't know the person yet, okay? And I don't know the problem that the person is suffering from. So I don't know if it's irritability is high, and I do something that is too much for him. I think it's soft, but for him it's too much, and then I get the patient much worse. Okay, and I say, okay, so I start with the lowest force I can, which is usually the patient-generated force, and then I try to push more according to the response. If the patient is not getting any worse and is not getting any better, okay, maybe you need a little bit more, okay? So it's going little by little. I'm increasing, building up my pushing, but I try to start with my hands on, and I'm quite confident. Not because of me, but I think the physiotherapy. I think with physiotherapy we have a lot of hands-off approaches. And I don't like to talk about names. I mean about techniques, okay, or movements that help us to change quickly the range of motion and to know if they are related to pain. So yes, mainly I start always. It doesn't matter if you're telling me that, okay, when you touch my muscle, it's giving me headaches. Okay, it's okay, no problem. But still, I'm going to see if I'm able to change things only with the movement, with the hands off. And of course, if it's indicated, because I'm not getting any response, I try to do something else with my hands, of course.
Okay, so that was my next question about the hands off, because I know your McKenzie background. And my question was, how do you use the McKenzie rationale on your approach? So I think you just said that. So you start hands off, and then according to the results, you're going to do some hands on or not. So is there cases that you can just do hands off and the patients get better?
Yeah, of course. If you do hands off and the patient gets better, it's all you need. If you have, okay, I'm good, I'm doing well, okay, don't do anything else. We found the source, we found the right area, we found the right segment or the right movement or technique with the right pressure. Okay, perfect. We don't need anything else unless the patient plateau or the patient gets worse. Okay. But if you find something with doing nothing with your hands, only explaining, showing the patient how to move or how to change the posture or whatever, it's all you need.
And then do you follow the same McKenzie rationale? If you try to provoke the symptoms, and then if they don't get worse or same, you continue, and then you progress with the same rationale as the method, or you combine something different there?
When you mean McKenzie rationale, what do you mean?
So, for example, you start doing retractions for headaches. Okay. Usually it's the most common movement, right? So then you have the pain, and then you do the 10 repetitions, and then the pain is not worse. Then you continue until you try to change the symptoms, right? Or if they get better, then according to their response, you are going to progress forces or not. Or if they're getting worse, you're going to stop and try something else, right? Okay. Is that kind of like the rationale?
So if you are not McKenzie, if your patient is getting worse, you keep doing the same thing? If you're not McKenzie trained?
I hope not.
Okay, so that's what my question was, because of that. Because we think, okay, McKenzie is green light, red light. I think we use this traffic light with anything we do. Okay, even in life. No, if you're talking to someone and we're chilling out, it's okay.
I think so. I hope so.
You know? If you start talking with someone about politics and someone is changing his face, you say, okay, change the subject, okay? So I think this is a life rationale, okay? Yeah. Because McKenzie really is a classification system, okay? So it's if you fit in one of the boxes that McKenzie said, okay, if you after my assessment, you are responding like that, okay, you are called derangement. If you are responding like that, dysfunction, whatever, and if you are not responding, okay, you are others, okay? So this is the rationale, okay? So the classification system. But what McKenzie does, is not different about what Mulligan does. Okay, because Mulligan says, okay, do 10 repetitions as well. And when you have flexion rotation test positive, that is one technique that is made by the patient, an auto snag, and it's 10 repetitions. Okay, so you repeat the movement, trying to go further. Okay, so it's not about McKenzie or Mayland, it's about names. Mayland starts with PAs and starts with grade 1, if not grade 2, grade 3, grade 4. So you are increasing according to the response you have. So I think the rationale is a normal thing, and it's the physiotherapy thing. But I know what you mean. Retraction, again, retraction is a movement that, again, McKenzie, by chance, got to know this, got to learn the movement, because he was using his system in the neck and he wasn't having the same results in the cervical like he was having in the low back, until he learned about one study of, I can't remember the name, I think it was Penning, Lawrence Penning. He was a guy from the Netherlands, I think, a neuroradiologist, who was the one doing radiographies, okay, X-rays, on the neck, doing retraction and doing protraction, and seeing that the neck is moving different as we thought, okay? And McKenzie said, okay, maybe we are doing this and we need to do this. So he was borrowing this movement from another guy, or this finding, no, from another guy. So retraction is not McKenzie. Retraction is a movement that's being existing. The only thing is McKenzie uses in a specific way, but other people does. When I was studying in the degree, I didn't know about McKenzie, and this was an exercise that they were teaching us for people suffering from neck pain, you know. But yes, I mean what you mean, and yes, my brain is structured a little bit like McKenzie, but I would say Australian physiotherapists, okay? Because I like the way they use physiotherapy, like they are doing a subjective examination, objective examination, and with all the information, they try to do the thing that the patient needs. And from that starting point, they going according to the response. So yes, this is the way I like to think and to use my rationale. Not to have technique and say, I don't care what you have, because I'm going to do the same thing to everyone. No, this is not working like that. You need to think about what person you have in front of you, and according to that, using what tools you need or you have in your box. Okay, but not just like that.
One thing.
Okay?
Yeah.
One thing. Yeah.
Whatever gives the results that they need. Whatever it takes, right?
Yeah, I tell you, if you have flexion rotation test, you don't need to do retraction. Maybe you have one technique that is published. The paper was published by Toby Hall and shows great results, and it's very easy for the patients to be done. It's hands on, hands off. The patient does it, and it's very easy, and it changes like that. So, okay, it's not a McKenzie technique, it's not a McKenzie rationale, but it works with someone with headaches. So that headache, very specific.
Absolutely.
Okay.
And what are the aspects that you think are important to be aware of while diagnosing and treating headaches?
Of course, you need to be aware of red flags always in any person that coming to the clinic. That's why we must do our subjective mainly, and of course after our objective if we need more information. But in headaches, of course, we also have red flags, and usually the problems giving headaches are inside the brain, mainly. You can have other things going on outside, like infections and everything, but mainly you are dealing with problems inside the brain, like cancer, tumors, things like that. And like in every area in the body, there is not prospective studies. They are always looking back. So we are learning from the experience, mainly in emergency. It's very important to know that red flags in headaches are very, very low. Okay, so it's not that you are having headaches and you are going to die. Okay, but you need to be aware that sometimes people with headaches are secondary headaches that can lead to a death. Okay. And there is an article that was published very recently with a rule. It was SNOOP, SNOOP. I think there were 3 O's or 4 O's, I can remember now. P10, okay, and it stands for several things, systematics, things like that. So I think there were 14 items, giving you clues that if someone is showing like that, okay, be careful. You need to refer this guy to further investigation. Yeah, so it's really important, and we don't have. We can, you can have people taking MRIs and CT scan and everything, but if you have a very good subjective and a very good objective, usually it's enough to say, okay, there is something going on here, or okay, it's safe for me to keep going with this patient.
Okay, so I'll make sure to find this article. We can talk later, so I can put this article.
I can send it to you later.
Yeah, I'll put the name on the show notes so people can check it out and
I'll send it back.
Take a look at these red flags that I think it's important.
Yeah, I'll send it back to you.
So now talking about resources for the ones that are interested in headaches and treating headaches. We know it's like an area that we don't talk much about it on the PT ward. So I know you teach a course. Could you tell us a little bit about how is your course, and also about like where do you think these PTs should start if they want to learn more about the topic?
Okay, as I told you early on, we live in a medical model with headaches. So we have a lot of things published regarding cervicogenic headache, but they are not always good, okay? So I usually try to take a look afterward with the systematic reviews with the meta-analysis and see what's going on. And there aren't many good articles relating to cervicogenic headaches. I like to take a look to every article that Toby Hall publishes, because I think he's a guy who is very, very, very good at headaches. Gwendolyn Jull from Australia and Toby Hall published, I think it was in 2018, a paper called cervical, how was it? Cervical musculoskeletal dysfunction in headache, something like that. How should it be defined, or something like that? Okay. Why in 2018? So we still don't have many tools to understand how to identify. You are asking me, how to identify from the pattern, okay, from the subjective, when a pain is coming from, a headache is coming from the neck. And we don't have many tests from the physiotherapy to really know when the patient is suffering from headaches related to the neck, apart from the flexion rotation test. So there is a world to be explored, okay? And of course, we have a lot of patients with similar patterns. We have patients with very different patterns, but we really need to be very structured, okay? We need to know what should we looking for. That's why when I'm teaching the course, I always say that my opinion or my perspective on here is you start always with the articular and start with the neck. Doesn't matter you have a TMJ problem, because some TMJ problems are also referred from the neck. Some people say, yeah, but you can have neck pain referred from the TMJ. Yeah, of course, but you start in one point and you can go all the way around, okay? So the thing is, once you start in one point, doesn't matter where you start. I can start in the neck because I'm confident with the neck. You can start with the TMJ because you are confident in the TMJ. Doesn't matter. If you don't find anything on the TMJ, keep going, okay? Keep going. And I start always with the articular, again, because it's easier for me. It's easier if we find a movement to the patient at home to repeat that movement, so to do the exercise at home. Whilst if you start with a massage, you do something here, okay, come in 2-3 days or in a week, during those days, what is the patient doing? Stretching or pushing or icing? What is he doing? So it's easier from the assessment point of view to start with the movement. And sometimes you have pain in the muscle, but it's just referred pain from the articular. When I mean articular, I mean related to movements, okay? Not that it's a joint, the problem. So I'm not talking about a structure. And again, if you are not finding anything in the neck, then go to the TMJ. And if you don't find anything, the TMJ, neck, articular, or muscular, okay, maybe it's not the patient for you. So it's always starting with the articular, trying to improve every loss of any range of motion loss. And if it's correlated to the improvement in the patient's symptoms or pattern, and from there, just keep going, yeah. And of course, this is talking about sensory, but we are treating people, and people are sensory, but they are also cognitive, and they are also emotional, okay? And people that have been told, I'm suffering 20 years from migraine, and they come to see a PTE, is like, what are you going to do with me if I'm a migraine sufferer, okay? And someone told me, okay, come to see that guy because he fixed my friend's migraine. If we are fixing a migraine, it was not a migraine.
Okay? Exactly. There is also these problems with diagnosis, names and classification.
Yeah, that's what I told you. This classification is just a tag or label. Okay, you are labeled with a name, okay? But it's not giving you the cause. There is no proof that you are having this. So it's just you are fitting in a pattern that has been defined by doctors, okay? And again, we live in the medical model, and the medical model is saying which is primary, which is secondary, and is setting all the definitions in the cervicogenic. Neurologists are named with cervicogenic or not cervicogenic. We don't have any clue about the name, okay? But with words, they are refusing about accepting cervicogenic headache. So there is a worldwide debate about cervicogenic headache exists or not. If they exist, they are just small, maybe 0 point something to 4%, maybe. Okay, but there are a lot of people suffering from migraine. If you tell me how much is a lot of people on my courses, one of the requirements for attending as a patient, because I see live patients on my courses. Because one thing is to tell about the theory, and one thing is, okay, and now I'm going to show you, okay? I'm going to show you how I assess the patient. Maybe it's okay for being treated, or maybe, okay, we cannot help that patient. And I always ask for migraine patients, okay? At least one has to be migraine sufferer, okay? And on my courses, I can tell you that not less than 30% of patients diagnosed with migraine after the last day of the course, they were 100% better, okay? Because I usually want the patient with chronic migraine, okay? I need you to be in the course with your pain. Not that, okay, I can have pain today, and in 6 months, I have my next attack, but my last attack was last week, so anything I'm going to do is not going to be related to your pain. So I need people with pain coming to my courses. And with these people, sometimes with 40 years or headaches, 20 years of headache, we've seen very, very good results. That means that there is not a migraine. It's a cervicogenic behaving like what we know or what we have been taught as a migraine. That's the thing with the overlapping of the migraine, cervicogenic, and blah, blah, blah.
Yeah, now the not following the classification that you said makes sense. I was reading a paper before talking to you. I think it was from England, I'm not sure. But they were saying that like 90-something% of the patients were classified as migraines. And they were like, that's crazy. So probably like they are not all migraines. So it's just hard to know how they're going to be classified, by who, what are the criteria. So you don't really know if they are true.
Well, they are just fitting into a pattern defined by doctors, by neurologists.
Yes.
So the neurologist, which is the specialist, they say, okay, headaches are our field. That scope is ours. Why? because headaches are a nervous system disorder. That's what they say. And that's why, because it's a disorder of the nervous system, we as neurologists, we are the ones in charge. And no one is saying, oh, no, you're wrong. No, they say, okay, you're in charge. And they are setting everything. Every rule is set by them. And it's okay, we can work together, but there are some sources like TMJ that they can worsen. Maybe it's not the cause, but can worsen migraine or tension time headache. We have publications backing up these things. Same thing with migraine. So I'm not saying that neurologists are wrong, but neurologists should be saying, okay, can you come and help? We can work together. Okay, I'm ruling out a red flag. Can you assess a patient, the neck and the TMJ? Why? Because if we have a neck problem or a TMJ problem, we quickly know if this is the case or not. If it's a headache problem coming from the neck or the TMJ, we are able to fix that quite quickly and lasting. If not, hey, okay, this is not working, now it's up to you. Hey, you start with all the medication and everything you need or whatever, or further investigation. But no, they are doing the other way around. They are giving all the medication. They're telling you, oh, you have a migraine, this is genetic, this is your brain is ill. When the patient is coming to you after 10 years, listening that your brain is ill, you are not, the medication is not working on you. Yeah, sometimes it's not working. Maybe it's your genetic. Your mom had migraines. Oh, yeah, but other people have migraine. Yeah, your mom had migraine. No, not at all. I'm the only one. Okay, well. Oh.
And how many you missing that you could be helping? I don't know, like the proportion of how many people that, like, for example, have headache that physical therapy could help, but I'm sure a lot of them could have some relief and some help if they try
that's it. Yeah, of course, 100% with you, because sometimes we have the neck as the only source and you have a 100% improvement. But sometimes you have a 70-30 or 50-50, So you may have a 50% improvement, but some people with 50% improvement can tell you, hey, now I can live. I have a life now with a 50% relief. And now my medication is working much better because when I have an attack, I take the medication, okay, pain goes away, I can control that. So always happen. I'm not saying it's black or white, so all the range of colors you want to have, but the thing is we can work together, and we as a physical therapist, we are able to know if we can help in very few sessions, so maybe in 4, 6, 5 sections, we know if we can help or not. Doesn't mean that the patient has to be fixed in 5 sessions, but if the patient now is responding positively to this. And maybe these 4 sessions are in 1 month or in 2 months or in 1 week, depending, because the patient is having attacks every 6 months. Maybe you see the patient today, okay, I will work with you, but I see you once a month until you have the next attack. Now you're having the attack, maybe I can assess you in a different way. So it's not going to be in 1 week, we know, but it's not going to take you long to know, and it's not going to be expensive. Medication for migraines are really expensive. The neurologists are charging much, much more than we are charging.
And sure.
So we are able to change quickly, and we are cheaper. And if not, okay, it's good. You enter in that field, that scope, and start everything. But not the other way around. After 20 years, you have a simple movement that is saving your life.
Yeah. And just curious, I don't know if you know, like, a number or just like an idea. So from the ones that come from help, do you think you are able to like improve even a little bit their quality of life, or that are like a lot of them that they just don't respond and they just need medication and you got to refer back to the doctor?
Well, in my experience, the main problem I found in the clinic is when people come thinking that you are not going to be helpful. Can come in just in case, okay, because I don't want to miss the opportunity, but I don't think that you are going to help me. So why you say so? Well, so many years with my headaches, okay, I learned this is not going to be fixed. My doctor says it's not going to be fixed. You can go to the physio. Okay, yeah, some massage is good for you. Okay, you can be relaxed, but it's not going to help you. So we have a lot of psychosocial issues here, mainly with the diagnosis, with the attitudes, with the belief, with the doctors. And just if you go to the internet and you read about migraine, you see associations, you see programs, you see everything related to migraine or cluster headaches or whatever, and everything is, oh, your brain is ill, nothing is going to fix you, your world is going to be awful, we are the second most the disability in the world, the second most disability disease, whatever, So it's really, really difficult to take the patient from here and to take it out of this thinking, So this is my main problem. So I need to educate a lot. Sometimes before I start doing something, I need 1 or 2 visits so I can inform the patient about, okay, what's about the migraine, the medical model, what we can do as a physiotherapist, But when someone is coming, okay, someone told me to come here, I want you to assess me, I'm open to do whatever you want. So, okay, let's see. And it's easy because if I find something, I can work on that, and it's going to be quickly known okay, you are responding, you are not responding. And if you find nothing at all, you say, okay, I find nothing at all, your neck is moving perfectly, we are doing everything, we are not changing anything, sorry, I can't help you. So it's easy, But when someone is coming with this mindset that mine is a migraine, there is no cure for her, it's really, really difficult. And there are a lot of those, yeah. Or people call me just because, hey, I have a patient of yours that is a friend of mine, and hey, in 2 visits, you fix him. Yeah, but you are not your friend. You are another person. Okay, maybe another neck or another. Maybe that person was a migraine from the neck, and you're not. Okay. Yeah. So I want you to do. It happens with the back. Oh, I have the same thing like my friends. No, you don't. You don't have anything like your friend. So.
Yeah. So it's worth the shot. It's worth to try and see.
Of course, of course. We have very good tools, easy tools, and I think we should see the headaches as a physical therapist in the same way we see knees, low backs, ankles, so it's not different. But it's just we are assessing a different area, and the pain is referred to the neck instead of being referred to the leg or to the arm. If someone is coming with pain referred to the arm, everyone is going, oh, okay, we are going to check your neck and see what happens. All very confident, our test, okay, move. Headaches, headaches, it's the same thing. The only thing is the top 3 segments, they refer pain to the head. Or the TMJ, which is another joint we can treat as a physical therapist, is referring to the head. That's it. So it's another joint, So how you assess TMJ? No, you put the hands there, you go, okay, open your mouth, close your mouth, move to one side, move to the other side, touch the muscle. Same thing like if we're low back, neck, elbow. So it's not different, they are joints, okay? And we are thinking, but headaches. If the headache is coming from that area, we are able to assess that area as physical therapists. It's same thing.
Yeah. And so let's transition to our final questions. Do you have any other resource of information that you would like to share other than like the articles you just mentioned previously? Mm-hmm. Any other things that you think are interesting?
Well, I'm always browsing PubMed. It's my main source of knowledge. I don't read books. I used to read books when I was a student because we didn't have any internet. So the only way was buying books. And sometimes when you buy the book, the things you are reading, they are just outdated. And well, that's it. So yes, usually PubMed is the main source I use because, well, at least there are articles indexed, and then the systematic reviews, as I told you, and meta-analysis, because it's a way of, okay, just sorting out the good from the bad. And I'm not very good at reading. scientific literature, because there are a lot of tricks that people can do when they are doing the articles, and I'm not very good at that. And mainly with headaches, what happens is that if you want to assess people with cervicogenic headache, we were discussing in the beginning of the podcast, how do you know that you have a cervicogenic headache? So how you get your sample for the studies? So usually what you have to use is the diagnostic criteria set by the IHS. So again, the medical model. But on the course, I explain as well the flaws of the diagnostic criteria regarding neck. Okay, because when the medical model and the doctors are thinking about the cervicogenic headache, they are thinking as well about the structures. When they say is pain perceived in the head from a primary source, they are thinking about facet joints, ligaments, and muscles. So despite you can show a lot of tests, they say, okay, but now you're going to publish something, we need anesthetic blocks. So again, structure. Okay, what about dysfunctions? Maybe it's movement. But it's not okay. And you doing the diagnostic blocks is not working. But you do a change in the posture, and the patient say, okay, my pain gone away. So yeah. So it's very, very difficult. So publications should follow somehow the IHS diagnostic criteria. So it's very biased, and I think we are not getting the whole picture of the cervicogenic headache, mainly from the physiotherapy point of view. So, as I said, this article from Gwendolyn Jull and Toby Hall is quite clear, and they say we need better definitions, okay, and better ways of studying this. So, and it was 2018, so that is our world ahead of us. Really, really interesting. And not explored.
Yeah. And what would be an advice that you give to the physical therapists that are starting their careers?
Well, I think something that was very helpful for me was to observe other people, to observe other physios. So you have a chance to observe other people. This is very, very good, because you will see many details that you don't see when you go to a course, because you can learn theory, you can read things, you can practice techniques, okay? But then you have to apply this on a person, And if someone is coming to through your door, and the patient is like that, a little bit scared because he doesn't know what's going on here, okay? What are you going to do on me, okay? And it's like that, and you are very technical. Okay, tell me. Okay, sit down. You start moving. The patient doesn't understand. You lose the patient. Okay. Sometimes said, "Hi, how you doing? Okay, yeah, okay. Tell me about your story." But so empathy is really important.
Yeah.
Okay? So if you see how other people are treating people, you may have a lot of inputs regarding this. Not only about techniques, because techniques you will have all the time in the world to learn techniques. But if you have a pistol and you don't know when to shoot it, why do you want to have this pistol?
Yeah.
So it's very important to observe. For me, observing was really, really, really important. And sometimes say, okay, I like this, or I don't want to do any of these things in my life. So seeing good physios is very good, and seeing bad physios is very, very, very good as well. So observe. And when you see someone that you like what he's doing, ask him, okay, what type of course you recommend me? Okay, what type of information you recommend me to do? Okay, so don't try to explore by yourself and thinking, oh, this is fashion now, I'm going to do this. Okay, now this is fashion. And okay, and we are just following fashion, okay? And there is the ABC is always working. So good subjective examination, this is always good. If you listen to your patient and the patient is aware that you're listening, you have done a lot. The patient is on your boat, it's a lot, because the patient needs to feel that you understand what he's feeling. Okay, so this empathy, I think, is really good. So good history taking, good objective examination. This is very important. And good objective examination is simple. Move. Show me how you flex your elbow. So the same thing. Show me how you rotate. as far as you can. Any pain? No, okay, just lay down. Okay, so you need your baselines, and baselines are easy. And then when everything, then you have to decide, okay, where do I see a problem? Do I see it in the neck? Well, not the lower. Okay, I forget about those things. Oh, maybe the upper. Okay, let's go. Flexion rotation test. Oh, I have a problem here. Okay, I'm going to start with the rotation technique. So, and then you're building up your rationale. But if you don't have your base, your foundations are really, really important. So the simplest, the better. Okay, and then you will have the time for everything. So, and for me, from the beginning of serving, you are going to learn a lot of those things to be really, really consistent and do those things and never forget about the basics.
Yeah, that's important. And what are the qualities and abilities that you think are important to become a successful PT? So I think you just mentioned empathy, right?
Mm-hmm.
And
which means good listening, good capability of asking questions, the right questions, okay, because we can ask a lot, but it's not about asking a lot, but asking the good questions. And maybe the first question is not important, it's the third question on the first question, So it's an ongoing interview, okay? And always with matters that are important. If you have a pain in your neck and you are 50 and you are suffering this for 2 months and you never had any neck pain before, it's a stupid thing to ask, did you fall when you were a baby? Of course, 1,000 times. 1,000 times, So things like that. So it's a question, but it's not related to this. Who cares about the fall of that guy when he was 1 year old? If he's been 49 years living without any neck pain, But we like to ask, maybe in the beginning, in the birth, when the doctor was doing this in the head, maybe then the bone. What the hell are you talking about? So try to ask sensible questions. You have to be really sensible and really focus on the patient's point. Don't ask the same questions to the same people, because even the same people from one day to other day, they are different. Maybe the first day they are scared, they liked the way you approached them, the way you did it, and they feel better. The second day they come, hi, how are you doing? They're smiling. Or they can come the first day, okay, how are you? And the second day, hi, how are you? And they're good. So they're different, okay? So it's not about one person, other person. The same person is going to be different. So you need to be flexible, okay? Because the patient is in charge. You are just guiding him, and of course, you know what you have to do, when you have to stop, what to change. And very important thing, you have to be very communicative. You have to educate people. If he's getting better, of course you have to educate him. But if he's getting worse, of course you have to educate him. And if he's not getting any better or any worse, you have to educate him. Because maybe they are expecting things. If I come to the physio, I expect to be better tomorrow. Maybe you're not, because we are still assessing. We are not treating yet. But the people comes to receive a treatment. They don't know the difference between treatment and assessment. We do, or we should do. We need to transfer this information to the patient so he knows that we are in a process until we know that if we can help him or not, okay? And I find this very, very, very useful. And when I was very young, if someone was coming, how are you feeling? Oh, I'm worse. I didn't know what to do or what to ask or what to, it was like, oh my gosh, the time is not passing by. Now,
what I do now.
If someone is coming now, I feel worse. Okay, why you say you're worse? And sometimes they tell me, well, my elbow. Your elbow? What's in your knee? Yeah, no, my knee much better, but my elbow, yesterday. So sometimes we think it's worse because of his problem and it's because of another problem, Why worse? Okay, why? Oh, because the exercises you show me. Okay, show me the exercise, and they're doing the opposite. Or they are doing the 10 exercises you were doing with them when you were assessing. So you weren't good at saying, only do this at home, So many things. So don't be afraid, be clear, straight, talking the same language that the patient understands. They are not doctors, they are not physios, they are people, they are scared sometimes, they don't know what they're coming for. So that's the thing. Empathy, communication, good ability to interview, and be ready to fix people and be ready to have people getting worse with your approach. But it's part of our assessment, so that's it.
Yeah.
We cannot help everyone. That's a pity, but we cannot help anyone.
That's also important to know, so we don't work too hard.
For me, it's the most important thing. When I understood that I wasn't going to be able to fix everyone, then I was more relaxed and I was enjoying much more my job, because I thought in the beginning that I have to help everyone, because I'm a physiotherapist, so there should be a cost for me. Sometimes you don't. And it's a very good thing. And it happened to me when I was 35 or something like that. So I was working for 12, 13 years, that you feel, Superman, okay, I'm going to fix everyone. and no, you're not. And now I'm 50, and the only thing I have clear is I cannot help everyone. But I tell them in the beginning, on the first visit, I tell them, I need to know if I find what happens to you and if I'm able to help you or not. And they understand. They are happy with that. Okay, so.
Yeah, I think it's important to have this very clear.
Yeah.
Pep, thank you so much for taking the time today to talk to us about headache, that I think it's like a delicate topic. People are scared of treating headaches. They don't really know how it works. So I think it's just good to bring some clarity on the topic and talk about it. So I really appreciate.
Thank you very much again for having me. And I hope that after the talking, the physical therapists start thinking about the headaches like just a symptom, and a symptom that can come from the neck, upper neck, or the TMJ. So they are joints. We are specialists at joint assessment and treatment. So go for it. Easy.
And before I forget, if people want to contact you, how they can find you?
Okay, so you are going to post some information, so I can give you my email. Again, you can post my email ID so they can contact me. No problem. Okay.
Okay, awesome. Then I'll put your email on the show notes, so if anyone wants to contact you, they know how to find you.
Yes, because I'm not very active on social media, so I have Twitter account and things like that, but I'm not very active. So if they want to reach me, they can reach me through my email.
Okay, awesome.
Yeah.
Thank you so much.
Thank you, Mariana. It's been a pleasure.